anywhere from prevention, diagnosis, treatment, living in a pandemic, and also various logistical and operational aspects of practice of healthcare, anywhere from employment issues to legal issues to financial issues. Really has been an honor to organize these sessions. I'd like to thank our CME committee, who's been working very hard, as well as our board, our president, Dr. Kevin Galastian, and the rest of the board members who have been, very active in and instrumental in organizing these sessions and bringing them to you virtually via Zoom, via Facebook Live, and also these sessions are archived where anybody can go and watch them, participate in the educational activities, and if appropriate, you can claim your continuing medical education units or continuing dental education units by taking the post-activity quiz, which is on our website, www.aamsc.org. A few announcements. We have another webinar that's going to take place tomorrow that is in collaboration with the Armenian Bar Association. We have two legal experts that specialize in employment law. And these experts, one of them will be discussing employment matters from the standpoint of the employer, and also employment matters from a standpoint of employees as it pertains to law and getting back to work in this era of the COVID-19 pandemic. So please make sure, put that on your calendar. We'll be starting at 7 p.m. Pacific, just like today. We will have several legal experts on the panel. Also, we will give you a short update to the past legal webinar that we had, which was on the Paycheck Protection Plan or program, or the PPP, as some of its requirements have been modified by the government, and we will have an update, a short update on that matter for you. So please make sure that you participate in that webinar tomorrow at 7 p.m. With that, I'd like to now introduce our speaker tonight. Our speaker tonight is Dr. Sherwin Hariri, who is a board-certified allergy and immunology specialist in Beverly Hills, California. Dr. Hariri completed his undergraduate educations at UCLA, where he received a Bachelor's of Science in Physiological Sciences and a minor in Armenian Studies. He then received his Doctorate of Medicine from the St. Louis University School of Medicine in St. Louis, Missouri. Dr. Hariri then went on to complete his internal medicine residency at Cedars-Sinai Center in Los Angeles, after which he completed his specialty training in allergy and immunology at UCLA West LA VA Fellowship Program with pediatrics rotations at Children's Hospital, Los Angeles. Dr. Hariri is a clinical instructor of medicine at the David Geffen School of Medicine at UCLA, where he teaches allergists and immunologists in training. He's also an attending physician at Cedars-Sinai Medical Center, where he sees and treats patients with complex allergic and immunologic diseases. Resident physicians from Cedars-Sinai rotate through his clinic, where he teaches them about his specialty. Dr. Hariri also published in several medical journals. He's a fellow of the American Academy of Allergy, Asthma, and Immunology, as well as a fellow of the American College of Allergy, Asthma, and Immunology. Dr. Hariri is the medical director at the Beverly Hills Allergy, where he treats both adults and pediatric patients with allergic rhinosinusitis, asthma, eczema, food allergies, immunodeficiencies, and various other skin conditions and allergic diseases. Dr. Hariri tonight is going to be talking about the cytokine storm, which so commonly occurs. At this point, I'd like to ask Dr. Hariri, please, to go ahead and engage your video, and please take over this platform, and I will go ahead and unmute myself and look forward to hearing your lecture. Thank you, Dr. Hariri.
Thank you, Dr. Sepilian, for your kind introduction. Good evening, everyone. Tonight, I am going to try to make a somewhat tough and not very interesting topic a little bit more clear by just reviewing basics of immunology, cytokine storm, and something that seems to be extremely important in this condition, COVID-19. Okay, and there we go. I have no conflict of interest to declare related to my presentation today. Cytokine storm and COVID-19. We'll talk a little bit about coronaviruses. Most of us know a lot about them by now, but we don't know much about effective treatment and cytokine storm in general. Definitely also not in COVID-19. We should start by reviewing basics of cytokine storm, cytokine release syndrome. Then we'll briefly talk about what seems to be important in cytokine storm and COVID-19. And then treatment options of the cytokine release syndrome and COVID-19. I'll be focusing more on treatment options that pertain to the immunology part, specifically some research that has been going on with IL-6 blockade and IL-1 blockade. And then we'll talk a little bit about the possible role of vitamin D in COVID-19 that got some attention over the last few weeks. Even though there's no good randomized controlled trials, obviously, for any of these, there is some reasonable evidence now for vitamin D deficiency and COVID-19. The Cleveland Clinic had this on their website, and I really like this diagram because it is kind of simplifying the three different stages or phases of COVID-19. So as most of you know, there is a very variable presentation of this potentially extremely deadly disease. And if you look at the stage 1, which is called the asymptomatic phase, that is basically the incubation period, which could be a couple of days to 14 days or even longer based on some reports. The viral response phase starts as soon as, I guess, you're infected, initially asymptomatic. Now, if you look at the red curve, you'll see that there is a turning point. Some patients will not follow this curve and will remain asymptomatic, and we don't exactly know why. Many patients will enter stage 2 where they have some non-severe symptoms. And at that stage, it's your cough, maybe low-grade fever, some of the more upper respiratory allergy/cold-like symptoms of nasal congestion, and some maybe eye symptoms, anosmia, smell and taste changes, etc. Usually not quite severe fever yet. And then there's that turning point when the really purely viral condition kind of turns into this hyperinflammatory phase or cytokine storm. And again, not everyone gets this extremely hyperinflammatory phase. Some people stay at stage 2 and never really develop to stage 3. And some patients will have a milder version of this somewhat hyperinflammatory phase where they'll see their fever starts around that day 10, 14, where they feel really bad and symptoms get worse, but then it quiets down. Now, in about 20% of patients, as most of you know, hospitalization is required, and 5% approximately will need mechanical ventilation. I actually wanted to mention that it says there's severe respiratory inflammation under stage 3, but as most of you know now, it's more of a multi-organ failure in some patients, and that is believed to be due to cytokine storm. So let's briefly talk about coronaviruses. So first of all, viruses in general, as you know, are small infectious agents of simple composition. They all have nucleic acid, either DNA or RNA, and several proteins. They require a host cell and need to elude the host immune defense to infect its cells, and that's how they can multiply and survive. They The coronaviruses specifically are enveloped viruses with a large plus strand RNA of about 30 kb in size, making it actually the largest known genome of any RNA virus. Sorry, let me see if I can move this window here. Okay. I can't see part of my own slides, but I'll try to deal with this. So coronaviruses have been identified in humans since the 1960s. Prior to SARS-CoV outbreak in 2002, they were known to mainly cause mild cold-like symptoms in humans. As a matter of fact, coronaviruses cause 15 to 30% of mainly upper respiratory tract infections in humans and rarely lower respiratory tract infections, mainly in those with chronic illnesses and the elderly. An interesting fact, by their 4th birthday, 75% of kids show antibodies directed against at least one of the known seasonal human pathogenic coronaviruses, which provide some cross-immunity and antibody-mediated protection against infection by other species within the group. SARS-CoV and MERS-CoV, just very briefly, most of us know about this, but in 2002, we had the novel coronavirus SARS-CoV that started in China as well, causing ARDS, about 8,000 reported cases with about a 10% mortality rate. Again, originated from bats. The transmission of SARS-CoV was actually very inefficient, only through direct contact, and there was very low infectivity during incubation periods. So when patients were asymptomatic, and hence containment by the end of 2003 was reached, and there was really no more cases we've heard of. MERS-CoV had actually a higher mortality rate, and this was identified in 2012 in Saudi Arabia and some other countries in the Middle East. About 2,500 reported cases, not considered to have been fully contained, but largely controlled by 2014. Mortality rates from 35 to 45%. Give me 1 second. So in December of 2019, as we all know, in Wuhan, there were some pneumonia cases of unknown origin, and the novel coronavirus SARS-CoV-2 was identified. It showed a lot of similarities to both SARS-CoV and MERS-CoV, but this one was now, SARS-CoV-2 was considered a pandemic, and the World Health Organization referred to it as a pandemic on March 11th. Today, 8 million confirmed cases worldwide, almost 428,000 deaths in 188 countries. Mortality rate, you know, going back and forth. Now we think it's less, around 1%, maybe less, 2%, but about 4 or 5% of confirmed cases is what we're seeing. And the United States with over 2 million cases and over 100,000 deaths. We discussed a very, very clinical presentation, literally from asymptomatic to quickly escalating to acute respiratory failure, multi-organ failure, requiring ICU admission, mechanical ventilation, and oftentimes, despite all that, quick death. COVID-19 causes about 8 to 20% of, 8 to 20% of patients with the disease, ARDS is seen. 14% of COVID patients develop respiratory symptoms requiring supplemental oxygen, and 5% need mechanical ventilation. Here's a simplified kind of diagram of the coronavirus SARS-CoV-2, the novel coronavirus, and we see the membrane M protein as well as the envelope E protein, the spike S protein, and then the nucleocapsid N protein. These are the four main parts of the virus, and these are the spikes, so to speak, that makes it corona. But I want you to remember that the spike S protein is basically what facilitates binding of the virus to the ACE2 receptor in humans. And the ACE2 receptor is found in many cells, and that's how the virus gets in. The M protein and E protein are considered to be less important. They basically form the shape of the virus, but less important in actual pathogenesis and do not really help the virus in getting in specifically. And then the nucleocapsid M protein is what holds the RNA genome. There are no good data on SARS-CoV-2 mechanism, infection, and immune evasion, but there is some. So interesting points that we should think of. So first of all, the amino acid sequence of receptor binding sites of SARS-CoV-2 is about 74% homologous to that of SARS-CoV-1. It's also about 50% homologous to MERS-CoV, and they both use the ACE2 host receptor. In both SARS, the S protein is required for receptor recognition and facilitation of viral fusion into the host cell, which causes irreversible conformational changes in that S protein we saw. ACE2 is almost in all organs in the body. It's highly expressed in surfactant-producing pneumocytes, so type 2 alveolar cells, as well as on ciliated and goblet cells in the airways. And so the virus gets right there in the airway system. It's also relatively highly expressed in the intestinal epithelium, hence we sometimes see patients with GI symptoms, also patients with mild disease, and on cardiac cells and vascular endothelia. At lower levels, ACE2 is also expressed on actual immune cells like monocytes and macrophages. In SARS-CoV infection, or in SARS-CoV, the infection of these immune cells was also observed. And this actually is also most likely an entry mechanism in SARS-CoV-2, where the virus directly gets into the macrophages and monocytes and directly can alter the immune response with pro and anti-inflammatory cytokines. So the host response and clearance of viral infections rely heavily on a cytokine called type 1 interferon, which you might have heard about. This modulates the cell response and reprograms cells into this antiviral state. And with type 1 interferon, pathogen is actually cleared. Now, in a proportion of patients infected with the novel coronavirus, the virus evades the immune system recognition through suppression of these mechanisms. And one thing to think of is that even though most of the cytokines are increased in SARS-CoV-1 as well as CoV-2, at least from what we know thus far, the type 1 interferon is actually decreased, and that contributes to not having that initial innate immune system response that is an antiviral response, and thus allowing the initial uncontrolled virus replication, resulting in delayed and potentially more increased cytokine response at later stages. And this is, if you remember the first graph that I showed you, this is still kind of the phase 2 going into the phase 3. Severe SARS-CoV-2 infection also results in CD4 and CD8 T cell lymphopenia and decreased interferon gamma producing cells. So cytokine storm. It sounds scary, and a lot of things are going on. Cytokines affect other cytokines, and you know, if you have release of one cytokine, then it does one thing on one cell, other things on other cells, and that's why it's very complicated, but it's also this vicious cycle that can get worse. And there's a couple of proposed mechanisms, and we'll look at a diagram soon to kind of simplify just the important parts, at least from what we know now in COVID-19, which pertain to potential treatment options. So a subgroup of patients with severe COVID-19 may experience this so-called cytokine storm or cytokine release syndrome. What is it? Simply put, it's a hyperinflammatory condition where the immune system produces an excess of pro-inflammatory cytokines, And those are then in an uncontrolled manner produced, and generalized inflammation throughout the body is seen, and that can affect multiple organ systems and often cause death. This was seen clearly right after the initial SARS-CoV-1 in 2002. And interestingly, with that infection and epidemic, and now with this pandemic, we're seeing again that during the most severe phase of the disease, viral titers actually seem to paradoxically diminish in both humans and several animal models. So there's less virus, more inflammation, more hyperinflammatory states, and ARDS, and often, clotting and multiple organs failing at the same time. Since the first reports of COVID-19, we knew that ARDS was the hallmark immune-mediated clinical consequence of this SARS-CoV-2, and it's known that this ARDS has about a 40% mortality rate. And it's due to, the inflammatory injury, as most of you know, with the alveoli and the capillary membrane, causing increased lung permeability, protein-rich pulmonary edema then in the air spaces, and that causes the respiratory insufficiency. Clinical features that we've seen with the SARS-CoV-2 as well as one is fever, respiratory distress, confusion, and coagulopathy. This, especially in phase 3, the hyperinflammatory state, where you also see lymphopenia, elevated ferritin, definitely often very elevated CRP in the hundreds, elevated D-dimer, elevated LDH, IL-2 receptor alpha. And this is often indicative of poor prognosis and a cytokine storm coming on. Cytokine storm has been used to describe some terms that you might be familiar with: macrophage activation syndrome, hemophagocytic lymphohistiocytosis, and then cytokine release syndromes. Macrophage activation and hemophagocytic lymphohistiocytosis are not common, but when they happen, even with high-dose steroids and appropriate treatment, which, we don't have great treatment, death can often occur. Cytokine storm can be caused by uncontrolled autoimmune diseases, by lymphomas, by chemotherapy, as well as viral infections. And SARS-CoV-2 seems to definitely be one of those. From this slide, I just wanted to quickly actually point at this hemophagocytic lymphohistiocytosis. If you look at patients that have heterozygous mutations of that same gene, but no disease, they have developed secondary hemophagocytic lymphohistiocytosis, which is cytokine storm, including sometimes fatal in H1N1 influenza. We don't know at this point what genetic defects, at least until a few days ago, we didn't know what genetic defects contribute to the severity of COVID-19 associated cytokine storm, but research in this field is definitely ongoing. A couple of terms, there's nothing that I can do to make cytokines really interesting and easy, but I just want the basics to be reviewed here. And so cytokines are a broad category of large proteins, or a large group of proteins, not necessarily large proteins, peptides and glycoproteins, and they're secreted by specific cells, and they trigger inflammation and respond to infections and inflammation. And cytokines are proteins that have a specific effect of the interaction between cells and the communication of those cells, as well as directly they can influence the behavior of the cell. They regulate immunity, inflammation, and hematopoiesis. Cytokines that are important are interferons, tumor necrosis factor, colony stimulating factors, the famous interleukins like the IL-1 and IL-6, which we'll discuss, chemokines, and also tumor necrosis, the tumor necrosis factor, which I mentioned. So Cytokines are produced by a broad range of cells, and they can be produced by multiple cells. The specific interleukin can be produced by more than one type of cell. Some cytokines enhance or inhibit the action of other cytokines in complex ways. And that's what creates this vicious cycle, including in COVID-19, and we'll look at that here in a few slides. Cytokines act through cell surface receptors. We'll go through this quickly. So interferons are basically a family of cytokines that bind certain receptors and result in the expression of genes. And so proteins with antiviral or immunomodulatory properties are made. And there is definitely interferons that are released in viral as well as non-viral diseases, and less interferon release can actually make some of these diseases worse. Hence, it's used therapeutically in things like hepatitis, as well as non-viral disease like multiple sclerosis. And also in COVID-19, we see that the type 1 interferon is actually initially not released. That's certain times more released, but generally it's less. And so the antiviral property, again, as mentioned earlier, is less. Tumor necrosis factor alpha is a pyrogenic cytokine that's usually released immediately as an acute phase inflammatory cytokine in infections. And it is associated with a number of infections and autoimmune diseases. Then you have the CSF proteins, and in this case, CSF stands for the colony stimulating factors. These are associated with inflammatory conditions and components of amplification cascades, where they draw production, the production of these cytokines draw macrophages to the sites of inflammation, and then there's this perpetual vicious cycle of inflammation with these CSFs. Not as big of a role, at least until now, based on most of the articles in COVID-19. Now, interleukins definitely play a major role in COVID-19, and they mediate traffic of immune cells to the site of infections, inducing the increase of acute phase signaling. They activate epithelial cells and mediate the production of secondary cytokines. IL-1 and IL-6 play a major role in COVID-19. Chemokines are also a large family of cytokines that have this very powerful chemotactic effect, and they're involved in the development and function of innate and adaptive immune system cells, but there's several chemokines that have been measured and based on some studies do play a role in COVID-19 as well. Now, regardless of the cause and mechanism of the different diseases, cytokine storm syndrome share features of inappropriately elevated pro-inflammatory cytokines. And they're produced by this dysregulated host immune response, resulting often in multi-organ failure. That is what cytokine release syndromes do, unless you stop the release of some of these pro-inflammatory cytokines. Cytokine storm syndromes are not identical. In certain diseases, certain interleukins or certain cytokines are released more, and the target treatment might be different. In COVID-19, we talked about the propensity for ARDS and the high serum ferritin levels, clotting, but the elevated level of IL-6 seems to be something that is definitely seen in a lot of these case series, and high serum IL-6, which is, by the way, IL-6 levels are easily measured. The high serum IL-6 levels were suggested as predictors for disease severity. In vitro studies also showed several circulating chemokines. Of note, CXCL10 is one of the main ones that I came across in my research here for COVID-19. And CXCL10 was used in several of these studies for prognostic markers, both in SARS as well as SARS-CoV-2. Now, the interferon response and SARS-CoV interfering with the appropriate interferon response is important, because initially SARS-CoV prevents interferon type 1 to be released, causing an insufficient type 1 interferon response. And that causes more pro-inflammatory chemokines, as well as the interleukins, to be secreted by all the different cells. When we're looking at this, again, there's no extreme viremia going on, of course, that causes the virus, but it's really hyperinflammation, it's really immunology at this stage. So Huang et al. Recently reported that infected patients with COVID-19 showed increased levels of what we discussed, the IL-1, the IL-6, the CXCL10 specifically. And this also points towards, T helper 1 cell activation. COVID-19 patients requiring ICU admission usually have higher levels of all of these. And several studies show that the serum levels are increased later on in disease, and when the patient is the most symptomatic, with the multi-organ failure, with the extremely high fever, and with the ARDS. So let's talk about interleukin 6. So cytokine storm is, again, this vicious cycle of inflammation. And the production of IL-6 is increased at the same time as the production of IL-1 and tumor necrosis factor, which is another cytokine, tumor necrosis factor alpha. And these two cytokines, IL-1 and TNF-alpha, increase IL-6 production. And we'll see that in a sec in our diagram. IL-6 plays a major role because it has a lot of different properties and functions. Now, in animal models of SARS-CoV infection, the inhibition of transcription factor of IL-6 levels was, and thus its production, was actually associated with reduced mortality. So in COVID-19, we have, which you might have heard of, the tocilizumab, for usually used for rheumatoid arthritis, a humanized anti-IL-6 receptor IgG monoclonal antibody as a therapeutic option for cytokine storm in COVID-19. We also have heard of Anakinra. There's also actually another anti-IL-6, which I won't discuss as much, tocilizumab, which there are some ongoing studies with as well. But tocilizumab has had more attention. And then from the IL-1 receptor inhibitors, again, the recombinant antagonist, Anakinra has been used for therapeutic, as a therapeutic agent for cytokine storm as well. We're going to discuss some of the studies with treatment in COVID-19 in a sec. So here, let's look, this is from clinical immunology, and you're looking at a not infected macrophage. So these macrophages are actually, go out of the bloodstream into the lung tissue, where there's a lot of SARS-CoV virus, and there's a lot of immune complexes with the not very effective antibody. And when these immune complexes are detected, they bind to the Fc gamma receptor that you see there on the left side in the diagram on this macrophage. These Fc gamma receptors are obviously all over the macrophage. In the diagram, it's on the left side, so A. When the immune complex is inside the cell, and these are not infected macrophages per se with SARS-CoV-2 through ACE2 receptors, right? Because ACE2 receptors are in small numbers found in macrophages. But when it's macrophages that are from, in the immune system, and then these uninfected macrophages invade the lung tissue, that's where they see the SARS-CoV-2 with the antibody complex, and then that gets in through the Fc gamma receptor. And so this is where cytokine storm starts. And let's look at these steps. So you see the SARS-CoV-2 there, and it gets activates a toll-like receptor 3 and 7, the TLR3 and 7 there. And this can induce two things. So it can induce the interferon regulatory factor, IRFs. And the IRFs, as the word says, are basically transcriptional regulators of type 1 interferon, which then you see there, the type 1 interferon is released. Now, this happens in a delayed manner because that step, the B step there, is actually does not happen or happens delayed in macrophages that are infected, and also in airway epithelial cells that are infected by the virus through the ACE2 receptor. When these cells are infected through the ACE2 receptor, the interferon regulatory factor is not induced, and that transcriptional regulator is not induced, and the type 1 interferon is then also not produced. Now, the IL-1, IL-6, and TNF are the cytokines there that are then released by C. When you look at the SARS-CoV-2, the TLR3 and TLR7 there, C will actually induce the NF-kappa B, which is basically the nuclear factor kappa light chain enhancer of activated B cells, and that induces it's an inducible transcription that induces the release of IL-1, IL-6, and TNF. Now look at the right upper corner, and I warned you, this is not very fun to look at, and it's complicated, but when you look there to understand a little bit of the basics that are proposed as the mechanism in this hyperinflammatory state in COVID-19, you see that IL-1, IL-6, and TNF are released, but then the cytokine receptor there binds to the cytokines again, and more IL-1 and TNF alpha will release more IL-6. And there you have that vicious cycle of hyperinflammation causing more and more hyperinflammation, especially when there is the virus complexes, which couldn't be stopped by the initial type 1 interferon release earlier on because of the infection. There's a lot of information on these slides about chemokines. I will try to just stick to CXCL10. So chemokine is a different type of cytokine, and they can directly activate apoptosis or recruit immune cells to sites of infection. They have this chemoattractant ability. And CXCL10 is a specific chemokine that plays a role in the onset of ARDS and seems to be playing a role in COVID-19. And if you look back here at this slide, if you look back at that type 1 interferon there in the right lower corner, the antiviral interferon, you'll see now that the CXCL10 also induces interferon. That's what it does as a chemokine. It's one of its functions. And so when the interferons cannot be produced and there is no powerful interferon response upon the first contact with this virus, the virus can multiply, and there's more virus, and then there's more viral SARS-CoV-2 and antibody complexes, so more is absorbed into these macrophages, and the cytokine storm takes place. We saw chemokines playing a role in SARS and MERS as well. There's little data on the relationship, exact relationship of these chemokines, and I don't think there's any ongoing treatment right now, but mainly CXCL10 is the main one. And there have been some studies described by Chinese physicians from early January 2020 that just reported that, CXCL10 levels, CXCL8, as well as CCL2, so all these CXs and CCLs or chemokines, they were all increased in COVID-19, especially in ICU patients with COVID-19. Chen et al. Recently characterized some of these immunologic features of COVID-19 by looking at 11 patients with very severe COVID-19 disease in the ICU that showed that all of these levels that we discussed of the innate immune system, as well as some of the adaptive, like the CD4 plus T cells and the CD8 plus T cells and T lymphocytes, being elevated with the interleukins and lower with the absolute numbers of the T cells. This was compared to 10 patients with moderate disease. Of note, severe cases were also characterized by low interferon gamma there, which activates the function of interferon gamma is to activate, macrophages, and it stimulates natural killer cells as well as neutrophils. So at all levels of the immune system, things that are not supposed to be blocked are being blocked, and things that are supposed to be blocked are not being blocked in a cytokine storm. Here it's a simplified diagram. Again, SARS-CoV-2 is inhaled or somehow gets, inhaled through inhalation into the lungs. And then if you look at the lung tissue there, you see that macrophages that go to the lung tissue and encounter the viruses, and then the dendritic cells as well as the T lymphocytes. So they're releasing all these cytokines, all these chemokines and inflammatory cells there, which causes the ARDS. So over the years, different treatment options have been used for cytokine storm syndromes. Treatment includes broadly immunosuppressive therapies for some of the genetic diseases or macrophage activation syndromes and juvenile rheumatoid arthritis, etc. Not common, but when it happens, often very, very severe disease. So glucocorticoids and calcineurin inhibitors have been used, as well as lately more targeted immunomodulatory therapies, such as the anti-cytokines like Anakinra or tocilizumab. So in regards to glucocorticoids, which are still being used in certain hospital settings in lower doses at certain hospitals as standard of care therapy, based on the previous experience with SARS and MERS, the World Health Organization initially did definitely recommend against glucocorticoid treatment with patients COVID-19, and the anti-cytokine treatment options were trying to be used more on a compassionate care basis. Here, again, from clinical immunology, you actually see the different treatment options that you have with COVID-19, and it's showing at what stage of these treatment options you're actually, what you're blocking with the different treatment options that we have in COVID-19. And I'm basically mainly going to focus on the anti-IL-1s and the anti-IL-6. We've had other talks on remdesivir and some of the antivirals, which is definitely not my expertise. But here you see all of them. So let's start from the beginning here. If you look at the SARS-CoV-2 virus particle there in the left upper corner with the anti-SARS-CoV-2 antibody. And then you also have the SARS-CoV-2 there by the ACE2 receptor. And so some things that you could do right there. So one of the first things that we can think of here is basically stopping the viral particles entry. So there are, again, no approved or evidence-based treatments for COVID-19. We all know that, but a number of treatments look a little promising. So convalescent plasma. So if you are giving the SARS-CoV-2 antibodies at high doses, well, that's self-explanatory. It'll stop the SARS-CoV-2, hopefully, from binding to the ACE2 receptor and causing the disease. Another thing that we can look at is recombinant soluble ACE2 protein. So if you look there at the ACE2 receptor, well, if the virus binds to a lot of recombinant ACE2, there might theoretically be a solution right there. It binds the SARS-CoV-2 and causes anti-inflammatory effects, and then it prevents it from getting in the cell and causing the damage. The famous or infamous hydroxychloroquine, which has been used, I believe, since the 60s in autoimmune diseases, potentially in combination with azithromycin, can definitely have antiviral properties. It can change the pH there in the endosome. So it basically reduces virus entry and replication, and this is known for a lot of autoimmune diseases and other viral infections definitely take place. But they also have immunomodulating effects that decrease some of the pro-inflammatory cytokines that we mentioned. Now, with this drug, obviously, again, no proven benefit, but if you start and also no benefit for prophylaxis, but in some patients, and this is just based on experience, if you start the hydroxychloroquine early on, and these patients might have gotten better anyway, but you might stop those processes, and some of these patients quickly improve if it started early on. Again, no good randomized controlled trials on this yet. Now, antiviral treatments, which we will not discuss, but that's self-explanatory. So those work by blocking the RNA synthesis there, or lopinavir and ritonavir are the protease inhibitors, and the nucleoside analogs are the remdesivir, and they can limit the actual replication of the virus. So interferon type 1, we discussed that. If we had more type 1 interferon, it actually might have a benefit, an antiviral benefit. We'll not discuss that in detail, but what we will discuss in detail is the immunomodulation of certain cytokines that were very important in the cytokine storm, causing the hyperinflammatory state. So blocking IL-1 signaling through recombinant IL-1 receptor antagonist Anakinra, and blocking the IL-6 signaling up there, which, if you stop the IL-1, it will also diminish, hopefully, or decrease the IL-6 expression. And if you stop the IL-6 expression, then you are also decreasing that vicious cycle of cytokine release, IL release. So less specific effects with IVIG and corticosteroids and some of the antiviral and anti-inflammatory effects of hydroxychloroquine and azithromycin also all still have to be studied in detail. So let's look at cytokine storm and then familial HLH data. Standard treatment of HLH, it should say there, sorry, that's a typo, HLF, is high-dose corticosteroids and calcineurin, as we mentioned, as well as a chemo with etoposide. And ultimately, in many patients, still death will happen unless there's stem cell transplantation on time. But because there is this somewhat associated cytokine storm syndrome, there might be some genetic similarities that yet has to be discovered. Now, they do both conditions have some of the similar laboratory abnormalities and some similar organ failure type presentations. And in 2016, it was the Schubert's study that showed that familial HLH was associated with fatalities in H1N1. So, okay, well, if we're looking at that, then we can obviously see if COVID-19 associates cytokine storm, which is definitely unique in certain ways because of some of the other ILs that seem to be more elevated, like the IL-1 and the IL-6, but something similar treatment might be beneficial in this case. Now, this is an infection, COVID-19, and HLH is not an infection. So this is more a secondary treatment, a secondary cytokine storm. And thus, things like cytotoxic drugs or stem cell transplantation are not going to be helpful. But hopefully, IL-targeted treatment will. In regards to corticosteroids and IVIG, looked at some of the studies, and overall it looks like high-dose steroids might not be beneficial in COVID-19, although they have helped certain forms of ARDS, but with complications, including avascular osteonecrosis in ARDS cases. Now, mild to, low to medium dose corticosteroids might have some beneficial effects, also from some Chinese cohort studies in critically ill COVID-19 patients. Let's look at treatment with anti-cytokine, a treatment of cytokines starting with anti-IL cytokine treatments next. And I'm actually going to go directly into the IL-6 receptor antagonist, which is tocilizumab. And let's talk a little bit about this monoclonal antibody. Tocilizumab is a monoclonal antibody that binds and inhibits the IL-6 receptor. ESR levels that are often elevated in COVID-19 patients, and definitely CRP levels, are driven by IL-6. This medication, biologic agent, is really only approved for rheumatoid arthritis, giant cell arteritis, and it's used in cytokine release syndromes. IL-6 is also seen elevated in autopsies of patients who died of COVID-19 in China, where lung tissue showed increased innate immune cells, macrophages and monocytes, and increased IL-6 production. So, kind of indicative of ARDS secondary from cytokine storm in this COVID-19. Couple of studies, some retrospective studies with not very good endpoint and some with better ones, but let's talk about 3 studies with tocilizumab briefly here. Zhu et al. Published a retrospective study in 2020 from Shanghai, China. There were 21 severely ill hospitalized patients, mean age is 50-some years old. And I apologize, I can't see half of my screen. But from memory, it's about 57 years old. And these patients were critically ill, confirmed COVID-19. Treatment was started with tocilizumab, 400 milligrams times 1 after 7 days of routine treatment, and which was antiretroviral lopinavir treatment with methylprednisolone in these patients. 3 of these 21 patients also received a second dose of tocilizumab within 12 hours if their clinical status did not improve at all or worsened. Treated patients had clinical improvement within 1 to 2 days and normalized temperature in all patients within 1 day. Patients had lower supplemental oxygen needs, and 1 patient needed no supplemental oxygen. And all patients were discharged home after 15 days on average. This is a non-comparative, retrospective, very small size study. But then Hassoun et al. Published in the Journal of Virology a case series of patients with confirmed COVID-19 by PCR. They were hospitalized in 2 community hospitals in Alabama and treated with tocilizumab. Here's the details. So mean age was 60 years, but it was a very variable age range from 37 years old to 88 years old. And as you see here, these are the 9 patients that ended in the study. There are males as well as females, and some with obesity, really 2, many with hypertension. And these patients all were treated with tocilizumab within 48 hours of respiratory decomposition. They all presented 7 to 10 days after the mild symptom onset, while they were, approximately in that hyperinflammatory phase, and all were admitted to the ICU except for 1. Average length of ICU stay was 10 days, with 5 patients requiring ventilation. 2 patients died. So 8 patients were left. 7 out of the remaining 8 patients had quick clinical improvement with either decreasing O2 requirements or successful extubation off their ventilators. Most patients noted an improvement in inflammatory markers in 7 days. Administration of tocilizumab in patients with COVID-19 exhibiting signs of cytokine release syndrome appeared to show some clinical improvement. However, the ideal setting and dose requires further study. One of the patients who expired from cardiac arrest after tocilizumab was given, but it wasn't clear if the cardiac arrest was a direct consequence from tocilizumab. As you see, the other patients all went home with self-care or home with family care. 1 or 2, I think, went there. 1 went to rehab, and 1 was still, 2 were still hospitalized once this study had concluded. There was not good post treatment follow-up. Now, recent larger clinical trials have started in Naples, Italy, really with hundreds of patients. But Dr. Paolo Acerdio is an immuno-oncologist in Naples, Italy. And in March, he started a phase 2 clinical trial, a single arm with tocilizumab, 8 milligrams per kilogram with a max of 800 milligrams. And then with a possible repeat dose again in 12 hours if there was no immediate improvement. Now, this is a much larger study. 330 patients with confirmed COVID-19 and inclusion criteria of O2 saturation less than 93% on room air. And if patients were intubated, they had to have been intubated for less than 24 hours. They looked at 2 primary endpoints, mortality rate at 14 days and mortality rate at 1 month. The mortality rate of the assumed control was without treatment with tocilizumab was 20% at 14 days and 35% at 1 month. Dr. Acerdo was hoping to find a 10% decrease in mortality rate compared to patients without tocilizumab. Results that were very recently released, and this has been submitted, the manuscript for publication, but mortality rate at 14 days was not significantly less, from 20% down to 18.4%, but the mortality rate at 1 month seemed to be 22.4% and seemed statistically significant. Again, the full manuscript still has to be published. But, the good responders were patients who were not intubated and who did have elevated inflammatory markers. The safety profile was actually pretty good. So common side effects with tocilizumab include transaminitis, neutropenia, and some infusion reactions. And these were seen in some, but generally, per Dr. Acerdo's report, it was well tolerated. And so we're still waiting to get all the details, but about 1,200 patients now with many early responders within 24 to 48 hours have been treated with tocilizumab by this group. And it's actually the International, I believe, Tumor Society of Italy. So we talked about IL-6 inhibition, receptor antagonist. Now let's talk about Anakinra, which is an IL-1 receptor antagonist. Anakinra is a humanized recombinant IL-1 receptor antagonist, and it's another pro-inflammatory cytokine causing various cytokine storms, preventing various cytokine syndromes that are caused by IL-1. There's several clinical trials studying IL-1 blockade in COVID-19, and there has been some improved survival. Huet et al. Published in the Lancet Rheumatology a larger prospective center cohort study, comparing it with a historical cohort study in Paris, France. This study is the ANA-COVID study with both a prospective cohort, as mentioned, and a historical cohort at the same hospital. They show that Anakinra significantly reduced requirement for invasive mechanical ventilation and death in patients who received Anakinra compared to the historical controls, who only received standard of care therapy. There were 52 patients who received Anakinra plus standard of care, and then 44 who only received standard of care. And in their publication, they stated that this was statistically significant. So the inclusion criteria here were patients of greater than age 18 who were admitted with laboratory confirmed SARS-CoV-2 and findings of pneumonia. So either on chest x-ray or on chest CT, or bilateral infiltrates on imaging that were typical for COVID-2. Also, these patients had critical PFTs, and it was all these patients were ward patients, so before admission to the ICU. These were the inclusion criteria, plus patients who had an O2 saturation of less than I believe it's 93% on 6 liters, or an O2 saturation of 93% on 3 liters, but with a loss a loss of 3% of oxygen saturation within the previous 24 hours only. So these are all patients about to go in full-blown ARDS or cytokine storm requiring ICU. The historical control group had the same inclusion criteria, but the historical control group was treated about 1 or 2 weeks prior. Patients in the Anakinra group were treated with subcutaneous Anakinra 100 twice a day for 72 hours, and then 100 milligrams daily for 7 more days, for a total of 10 days, plus standard of care. The main outcome was a composite of either admission to the intensive care unit or death. And we see that admission to the ICU for invasive mechanical ventilation or death occurred in only, or it's still a large number, but less. So 25% of the 52 patients in the Anakinra group, which was 13 patients, versus 44 patients, or 73% of the 44 patients in the historical control group. This was statistically significant. O2 requirements were also significantly reduced with Anakinra. Multivariate analysis was used to control for potentially confounding factors, and they did not find any change in their conclusion. However, this is not a randomized controlled trial, and it's a non-blinded study. The only adverse effect was mainly transaminitis, but it was 13% versus 9% in the control group. So Anakinra can be given IV or sub-Q, but in this study, it was given subcutaneously, as mentioned, and it looked like it reduced both need for invasive mechanical ventilation in the ICU, as well as mortality among patients with severe COVID-19 without serious side effects. And that study was in France. The next study is in Italy, and this was done in May, and it's in Milan, Italy, where patients who were 18 years or older with moderate to severe ARDS from COVID-19, and then hyperinflammation, so a CRP level greater than 100 or ferritin greater than 900 were included, and they were managed with non-invasive mechanical ventilation outside of the ICU. So all of them were on non-invasive mechanical ventilation, and they all received standard of care treatment with the antiviral as well as hydroxychloroquine 200 PO BID. Compared to the control. So mechanical ventilation-free survival and a lower CRP, as well as improvement clinically and respiratory function and clinical status in the cohort of patients who did receive the Anakinra, which was a high dose 5 milligram per kg IV BID or 100 milligram sub-Q BID, with a retrospective cohort of patients who only received standard of care. Outcomes were assessed in both groups at 21 days. And these also, again, were done in March, the treatment, and the non-invasive ventilation standard treatment cohort was done about a week prior. What happened was the 7 patient that received that low-dose subcutaneous anakinra, that treatment was stopped because there was not effective improvement clinically or in the CRP levels. But the high-dose anakinra at 21 days, just like the French study, again, showed improvement in respiratory function in about 72% of the 29 patients. This was considered statistically significant. In the standard treatment group, only 50% showed improvement in their respiratory function and thus prevention of ICU on ventilation or death. So if we look at this, then at 21 days, survival was 90% in the high-dose anakinra group and 56% in the standard treatment group. Mechanical ventilation-free survival was 72% versus 50%. As an adverse effect here, bacteremia was mainly noted, but it was similar in both groups. And discontinuation of anakinra was not followed by inflammatory relapses shortly after stopping. In this retrospective cohort study of COVID-19 and ARDS managed with non-invasive ventilation outside of the ICU, treatment with high-dose anakinra was safe, and it was associated with clinical improvement in 72% of patients versus 50% in the control group. Again, non-blinded study and not randomized controlled. Some, these basically treatment options show some hopeful potentially benefit. Not everyone responds favorably, but the side effect profile seems pretty safe, and most people, 70%-ish did well. In the vitamin D supplementation in COVID-19, very briefly, I would like to touch on this subject. Some of you might know about this and maybe know more about this than me, but first and foremost, there's some evidence that vitamin D plays a role in allergies, which is my bread and butter. And in allergic diseases like anaphylaxis, some studies from about 5-6 years ago actually show that patients who had lower vitamin D had more anaphylaxis. So we know that vitamin D has been known to be important for other things in addition to bone health. And so epidemiologic data have shown that vitamin D is important in, low levels might have increased risk of cardiovascular diseases, metabolic diseases, infectious diseases, autoimmune diseases, and possibly allergic diseases. And, since there's no vaccine, no really effective treatment, some supplementation with a vitamin that is usually harmless at appropriate dosages or even a little slightly higher than recommended dosages might, kind of be a treatment that we might want to use anyway. Since it can't really hurt. So vitamin D receptors are expressed on multiple immune cells. And we know that vitamin D can modulate both innate and adaptive immune responses. So even in cytokine storm, if there is a sufficient vitamin D level, that you might say that it might, prevent that hyperimmune state that we talked about. So if we look at a meta-analysis of randomized controlled trials of vitamin D supplementation, we see that in acute respiratory infections, high vitamin D levels actually improve outcome. The evidence that we have so far for COVID-19, there's some, they're not randomized controlled trials, they're mainly observational studies, but some of them are kind of good. And I know they're starting, or they might have started randomized controlled trials in COVID-19 patients at Harvard. But one study that we should look at is this study from South Asia. And if you look at these patients that were treated in the hospital as well as outside the hospital, but 212 COVID cases. And if you look at the critically ill patients, look at the green bar. So the green is the percentage of patients with therapeutic levels of vitamin D. Only 4% had therapeutic levels of vitamin D of these critical patients. but 44% had low levels and 52% had severely low levels of vitamin D, less than 20. Now, if you go from critical to severe, you see that it's similar. But if you look to kind of like moderate levels, and then if you look at, moderate COVID, you see that there are some more patients with therapeutic vitamin D levels, and then or normal vitamin D levels. And then if you look at the mild cases, 96% had normal vitamin D levels. Then researchers were wondering why we have, different mortality rates in these different countries. And although, differences in healthcare were looked at, we know that healthcare in Northern Italy is actually pretty good. And even before their ICU system was overwhelmed, there was a high mortality rate. So a couple of studies then were published, and researchers at Northwestern University in Chicago analyzed data from 10 countries with significant number of cases and of COVID, and the US, UK were included, as well as China and Iran and Spain and Germany. And patients in Italy and Spain with a higher COVID-19 mortality at the time, as well as the UK, seem to have lower vitamin D levels. Another study from 20 European countries showed the same, that decreased vitamin D levels patients had increased mortality rates in these COVID patients. Now you might say Italy and Spain, there's more sun, but these patients avoid the sun more, especially the elderly patients that have chronic conditions and are at risk for the critical illnesses, as well as more skin pigmentation, so less synthesis of vitamin D from sun absorption, and so less vitamin D is made. But then interestingly, we saw that Scandinavian countries, now some of them are unique with no social distancing, but in general had somewhat better mortality rates, and they have higher vitamin D levels also because of supplementation and cod liver in their diet. Lastly, just to touch briefly upon patients who are in institutions, hospitals, and nursing homes, there's obvious reasons for these patients are usually chronically ill to catch COVID-19. Also, they're in a confined space, but 75% of the patients had low vitamin D levels due to being indoors, maybe due to chronic illnesses and just not taking supplementation. And so, these patients have higher mortality rates as well. So we can't make great conclusions, but there is some evidence that vitamin D, at least patients should have therapeutic vitamin D levels, or normal vitamin D levels, I should say. About 800 to 1,000 units a day should be recommended probably in people, and you can probably go up to higher doses in some patients if no contraindications. So in summary, I just wanted to, again, summarize that cytokine storm seems to be really real in COVID-19 from what we know so far. And since there's no effective vaccine and SARS is extremely contagious, this is millions and millions of people are at risk globally. And it appears that this hyperinflammation caused by COVID-19 and its host may result in this cytokine storm with the high mortality rate. Therefore, we have to understand the immune system, which we still don't fully do in SARS-CoV-2, but treatment should or might need to be directed at this phase. Now, of course, if we can prevent patients from ever getting to that phase with the other treatments, that would even be better. But we do need randomized controlled trials for the anti-inflammatory treatment options. And we know there's ongoing studies worldwide. And this is really what I wanted to share with you in my talk today.
Dr. Hariri, thank you very, very much for this really informative lecture.
There's what you can do to make cytokines interesting.
Yeah. Well,
thank you, Dr. Hariri. We appreciate that. If you can disengage or share screen, and so we can see you. And there are some great questions, and Dr. Barkhudarian is going to moderate the Q&A session.
Sounds good. Thank you, Dr. Sapilian.
Yes, and frankly, I wish I was sitting next to Dr. Sepelian, where it seems like the weather is much better than in my office here.
I know, same here.
Well, very, very much appreciated. This is a complicated topic, and I must say, I think many practicing physicians and clinicians, this is somewhat of a black box area, but we don't really, as you said, the immune system is tough to understand as it is, and we don't have enough information with this interaction with SARS-CoV. So it was a great foray into what we know so far. We did have a few questions that came up, some of which are related to treatment options and some are mechanistic questions. But just to start off, obviously, we recognize that the cytokine storm is bad and patients who undergo that have a high chance of mortality. But just from the data that you've seen, those who survive cytokine storm, compared to those that did well and maybe didn't have it or were hospitalized, whatnot, with SARS-CoV-2, how do they do in the long run? Do we have data yet to see if there's any lasting effects of this cytokine storm on the overall patient health?
I don't think there's a lot of data, and if anyone does have data, let me know. I didn't find a lot of data on this, but there's case reports, and there have been some cases that we heard of where if patients were generally older, because there's younger patient with cytokine storm too, we saw some cases where there was some lung damage and reactivation after stopping Anakinra, for instance, which was used in some patients where it was used again for several days, and then the patient was doing well, was discharged, but never was able to really stop the supplemental oxygen at home, and then redeveloped symptoms again. I don't know of great data at all, but I've definitely seen cases like that and heard of cases like that. And some of these patients had to be restarted on the Anakinra. So again, one thing that we absolutely don't know is how long we should treat these patients with Anakinra. It's kind of like, you know, whenever we have the Anakinra and we treat the patient, and some of these patients also are getting the plasma at the same time concurrently, so we don't really know what is helping the case. But what happens is, because there is damage in the lung tissue itself as well, some of this tissue damage might, you know, not be reversible. I don't think I know enough about this with COVID-19 specifically at this point, but I'm fearing that from the cases that we're seeing in some of these severe cytokine storm patients that they improve generally, but some remain symptomatic, specifically with shortness of breath and critical PFTs, etc.
Thank you. Yeah, it's ours. Maybe tough to answer question, but commonly asked question I have to say from patients.
Yeah, and patients also often, you know, we definitely think this is a reactivation. Sometimes patients have presented a month after having been discharged and having been re-exposed to family members, maybe who had a milder, you know, or later onset symptoms, but mild, like a child or a younger family member. And then is it reinfection? Is it reactivation? But the symptoms seem to be, you know, reactivation of the CRP that was 200 that went down to, you know, 20, and the patient was discharged, and then it's back up again. That we've seen.
Well, actually, what you just mentioned brought up another question we had. And, you know, we did have a lecture on multi-system inflammatory syndrome in children, which is also an immune-mediated syndrome, but obviously somewhat mechanistically different. And it happens in a patient population that is less prone to the cytokine storm. So I was wondering if there's any relationship with those two syndromes, mechanistically and also from a treatment perspective as well.
I actually don't really know what the exact mechanism is in those few cases that they've seen. I know there is the same of the increased interleukins that we see here as well. I don't think we exactly know, you know, I kind of focused on what we do know at this point with the IL-6 and the IL-1 and the interferon type 1 interferon being decreased initially, which delaying the release. I don't know if that is what was seen in the pediatric population, mainly because 90% of who I see is adults. I'm adult trained. I see kids for allergy, not really as much immunology, but I know that some of the same interleukins were released. Now, this can happen with any viral disease, especially in some kids, as you know, and Kawasaki type syndromes can happen. It's extremely rare in kids. But I think we need much more data on that topic. I'm sorry, I can't help you as much with that.
Yeah, thank you. There was a question by one of the audience members, so one of our doctors, Tigran Avoyan, and it has to do with the glucocorticoid use that you had mentioned and the dosage of that and whatnot. But his question was more for practicing physician. Is it okay to do intra-articular, paravertebral, or epidural corticosteroid injections during COVID? Is that something that's safe and acceptable?
Yeah. So even systemic steroids are sometimes used. And I know from some of the hospitalists that mentioned at Cedars, especially, I don't know if everyone's using it right now, but 40 milligrams a day, 20 milligrams, 60 milligrams a day was being used systemically. So I assume that it is safe to do those topical injections of steroids if needed. I really do if the patient is stable. But is the question specifically when it should be done? Like what's the question specifically mentioning? If someone is acutely ill with an infection, in general, I wouldn't do it. I don't think there is great data that I know of for this at all, but systemic steroids have been used. Most people don't do horribly worse. Actually, it sometimes helps the ARDS. We really don't know is the answer, but I think topical steroids are not the biggest problem here. If patients are generally stable and definitely if they're on some other treatment that seems to be working, then I don't think there's a problem to do it, especially 2, 3, 4 weeks after presentation.
Right. Dr. Avoya just commented that he was talking about for acute pain resistant to the treatment. So from a pain perspective, maybe the better way to phrase this question is, should we be testing these patients for COVID, and which patients would we restrict care on and which would we proceed?
Good question. Glucocorticoids generally can actually suppress the pro-inflammatory state, specifically the one that we discussed. In the hyperinflammatory state. And because patients' hyperinflammatory state in that phase 3, there is already less usually viral replication and viremia, at least from what I studied, it actually should be safe to use small amounts of steroids topically. I don't know, again, of any studies. I don't think you need to screen everyone for COVID-19 who you're going to give subcutaneous or any type of steroid injections. I'm not doing that in my practice. If asthma patients come in and I'm sure that it's asthma, not everyone is being screened for COVID-19, but in general, I think we're going towards having to know people's COVID status anyway. But if someone is in acute pain and has absolutely no symptoms, I don't think you necessarily have to check for COVID. It has not been disastrous per se from what we've seen when given.
Very good. So we have a couple of questions with regards to vitamin D, and obviously that's an attractive topic because it's easy to give, and obviously we know some of the side effects of that. So a couple of questions. One is, looking at the data that you showed. Yes. It occurred to me, and you may have touched upon this, that the patients that had severe disease or were hospitalized had already been indoors for quite some time, and perhaps just because we were assessing them at the time of their acute level of care, their vitamin D levels may have been lower than somebody emulating outdoors and coming in. So I wondered if that was assessed in that study. And then the follow-up question would be, if we were to treat vitamin D, would we try to aim for a normal physiologic level, or are we trying to go super therapeutic or pharmacological levels of vitamin D? Yeah.
So this is what I would, so yes, I'll try to answer that. So vitamin, first of all, you are absolutely correct. about the fact that there's all these other confounding variables, and these are observational studies. They're not the best. It was not accounted for from what I remember, definitely not in the Southeast Asian study with the 220 COVID patients where I showed the graph. The sicker patients are going in more sick, so they do have less sun exposure. But the problem is that the only thing that they looked at is the vitamin D level. They all did have lower vitamin D. So regardless of why they had lower vitamin D, they had it. And when you have lower vitamin D, you have less of the anti-inflammatory mechanism with vitamin D, which is a lot of different things. And so you're more susceptible, is what they're saying, to the cytokine storm and thus critical illness. Critical illness for an immunologist, based on the little data that we have, is really 99% cytokine storm, or a hyperinflammatory state. And if vitamin D can prevent that, or having a therapeutic level can prevent that, great. Now, in all these studies, they were looking for normal vitamin D level or low, mildly low, or critically, low levels. And from the studies in general, from respiratory infections and ARDS, we know that in patients with critical vitamin D, low vitamin D levels, if you give them high doses of vitamin D, I don't remember if this is ICU patients per se on intubated or not, but these are older studies. If you give vitamin D levels at extreme levels, so you can more quickly bring up the levels, it actually quickly improve patients' symptoms and survival. So that's not COVID patients. In COVID patients, we just don't have enough data. But here's the thing. I think that the studies from Harvard will come out, and what they're going to do is, if I'm correct, is they're going to give 800 to 1,000 units, which is answering your second question. So, kind of a conventional dose that's usually recommended, and then checking levels. Plus, they're going to give higher doses. As you know, 4,000 up to 5,000 units a day usually cannot hurt you in most people. And what I've been telling my patients, but only because I see some patients with autoimmune diseases, and there's been some, case reports, et cetera, patients with autoimmune diseases and allergies just doing better when they're on 2,000, 3,000, 4,000 units. They have lower ESRs, and it could be other things, but we give it, and we have never had a problem. So if okay with other doctors, usually what I recommend is 2,000 to 4,000 units. Again, not based on any very good data, but that is going to come out. And I'm very hopeful that it'll show some benefit, hopefully. Such a cheap, right, and safe preventative measure, safer than even hydroxychloroquine, if that's going to be the prophylaxis.
Which is very, very appealing. There's also,
very appealing.
Yeah, there's also a follow-up question to this by Dr. Zara Ashikian. She was wondering if there was a possible reason why Hispanics and African Americans are experiencing more severe cases of COVID-19, and could that be due to vitamin D deficiencies since they have darker skin colors, and maybe perhaps they're making less vitamin D naturally?
That's a very, very good question that comes to mind every time I read these studies, especially the last one where they were trying to explain why the elderly in the Southern European countries, who usually have more hyperpigmentation, actually had lower vitamin D levels and also higher mortality rates. Yes, it could. I mean, there's a lot of different things that could be a player here. Unfortunately, some of those patient populations have more chronic conditions. There is also obesity at play and other things, but access to care and this and that. But one of the things could be vitamin D. And there's not much that has been, at least from what I've read, there's not a lot that actually is suggesting that vitamin D is not playing a role at all or hurting it. So, and that's something that I don't know if it's actively being looked into, but I can look into that. I can get back to the doctor if interested. And because I am going to connect with some people doing research in vitamin D and this COVID-19, but that's a very good question. And it potentially could be a reason. I don't know of any major immunologic differences racially, or ethnically. So, with this potential, with the cytokine storm, but something that is different is the skin color and the hyperpigmentation, and maybe the synthesis of vitamin D naturally.
Yeah, that would be great.
I wish I had straightforward answers, but
well, it's a tough topic, I have to admit.
very interesting. But I really feel that maybe in about 6 months, I will be able to discuss this vitamin D topic in more detail and with better answers.
Well, we'll probably need to do a follow-up then to address those.
Yeah.
Moving more towards the bigger guns here now, the tocilizumab and the Anakinra, the IL-6 and IL-1 inhibitors. The data seemed very compelling, and I think we're still learning about some of the nuances there. But just from your perspective, maybe from a 30,000-foot perspective, do you see one better than the other? Is there a possibility that we would actually combine and use both at the same time? I don't see any studies on that yet.
Yeah, I don't think these biologic agents have been used at the same time in anyone. They definitely have been used obviously with remdesivir and some of the antivirals, as well as hydroxychloroquine and azithro. And what was presented in some of the studies was what was standard of care was hydroxychloroquine and azithro in the French study, and then the antivirals in the Italian study as well. So no, we don't know that yet, but it looks like Anakinra is used more right when that hyperinflammatory state is starting, because the studies for Anakinra are patients that are not intubated and that are not in the ICU and are on non-mechanical ventilation outside of the ICU. And it works pretty well, like 72% improves, right? So, and the side effect profile, I would say, is possibly even safer than tocilizumab with the transaminitis, which sometimes can be bad, as well as the neutropenias, which you don't see as much with Anakinra. Now, with tocilizumab, usually, or at least in these studies, patients were sicker, they were intubated. And so we were looking for extubation in these patients. And that increased the survival somewhat, right? So we saw that from 35% really death at 1 month, it went down to 22-point-some%. This was looking at all of them. Now we know that ARDS patients, once they're intubated, still have 40-50% mortality if there's no intervention at all. But yeah, so I think that they will have potentially different, slightly different patient populations. That Anakinra, I think, will more quickly be approved because of its profile and because case reports, including here in Los Angeles, seem to work very well in conjunction with plasma in some patients. Again, a more early phase treatment, the plasma itself as well. Critically ill patients, but you're really targeting the viral phase. So again, I think that some of these data are actually a little bit encouraging. We need the randomized controlled trials. I'm going to follow up on that Italian study with Dr. A, where they now have enrolled 1,200 patients. And I think it's part of the national, I'm blanking out, the national research website that we have here, the national NIH something.gov.
Trial registry.
Yeah, the registry. And it's part of that one. That big study is going to be hopefully a very well-run randomized double-blind controlled study. The other thing is, right now with the open studies, I wonder if in Italy they gave these medications more to the younger patients compared to the control. It was similar, but some of them. So there's always a little bit of bias. Patients with Anakinra, though, a lot of them really do improve even when they're really about to be intubated. Tocilizumab, I don't think, has been used in as many patients who were not on mechanical intubation.
That's very comforting to hear, considering a lot of the lectures we've had so far has been very uncomfortable.
Yeah, these are not the best studies, but it's also being used more and more. I mean, patients initially were just given remdesivir, right? Yeah. If they were critically ill, or plasma, and then they started with the tocilizumab and Anakinra more now.
Yeah. Well, I think we have time for one more question. I think this is a good question to wrap up with. This is from Harut Bronosian. Practically, how can those in quarantine at home increase their immune system and reduce inflammation and be preventative from being hospitalized? And what is the role of vitamin C and probiotics for improving the immune system and reducing inflammation for COVID-19?
There's no proven benefit in vitamin C. We know that. It's all anecdotal. And so the zinc and the vitamin C, you can take a few thousand milligrams of the vitamin C, but there is no benefit in preventing cytokine storm, which is what we need. With vitamin D, there might be. In regards to when you're in quarantine, the only thing that's been proven to do is to get out and get some sun and to do exercise. There's really no magic immune pill that I can suggest, or anything really I can suggest, honestly. It's a very weak answer because we don't have any treatment in that field. And if we did, we would probably win the Nobel Prize. But there is really, in quarantine, what I suggest to my patients is physical exercise, is getting yourself in as good of a state as you can, managing your chronic illnesses. One last thing that I should mention that I remembered. So patients who have autoimmune diseases or malignancies that are on disease modifying agents that tend to suppress the immune system, probably, and I think most national and international societies agree, should not stop their disease modifying agent, even if they are well controlled and have been and might have come off of these meds, and then just switch to hydroxychloroquine, which I've had family members do, and I initially agreed with it, but it looks like because of this cytokine storm that some of these disease-modifying agents, being on one does not put you at higher risk. Suppressed immune systems just because of chronic conditions, yes, but the treatment of those doesn't necessarily put you at increased risk. So you should continue that. So if you're in quarantine and you take any of those medicines, absolutely continue. Now, steroids are a risk, we think, but the disease-modifying agents might prevent cytokine storm. Other things are just physical, exercise, and healthy heart, healthy diet, and that's all really that I suggest to people. Yeah, of course, people are worried when I'm in quarantine, your immune system gets weaker, you're not interacting with people. Yeah, you have less triggers for the immune system to make antibodies. That is true. But at this point, it's really the only hopefully effective thing that we did. And now it's back on the rise. So I don't know. I'm a little worried about, especially within also, now in Los Angeles, a big city like ours with multiple cultures, including ours, we like to be with family and friends, most of us. It's a problem. It really is, I think, going to be a problem, but we'll see.
Yeah, I'll just follow that up with something I've said on this platform a number of times, that social distancing works. And, I was just scolded by a patient of mine today that he was in the hospital and he saw a bunch of people not wearing masks and, taking care of patients. And, it's up to all of us to encourage our patients to wear masks, and even just people in the public, and really be a voice for that, because there's so much going against that in the social media and some even in the newsprint, that we really have to take our role as physicians to disseminate that information.
100%. I know we're all sick of the virus, but the virus is not sick of us, as we keep saying, as I keep telling patients. And social distancing definitely worked in California, but let's see in the next 1 or 2 weeks what's going to happen.
Right, and indeed, it is something that has some great science behind it, evidence-based support behind it. And by social distancing, it may be a misnomer. It doesn't mean that we socially distance ourselves from loved ones or colleagues or whatever have you. It's the actual physical distancing, but there definitely is strong evidence behind it. I'm actually very happy to see that our entire audience is still engaged on the Zoom platform, as well as we're on Facebook, and there's many people watching, do heed those advice. It's not that burdensome to stay a few meters away from people. It doesn't make us less social. We just have to rethink our social interactions with the ones we love, with our colleagues and our workplaces, as the workplaces are opening up. Dr. Hariri, I really want to thank you for this extremely informative and very scientific and evidence-based lecture. Dr. Barkhudarian, I also would like to thank you for moderating the Q&A session in such an excellent way, as you always do. We will definitely have a follow-up. In fact, we're in the process of organizing a lecture on the role of micronutrients in COVID-19, including vitamin D and other micronutrients. It's very important, as you stated, Dr. Hariri, that we take an evidence-based approach. In the acute panic phase of this pandemic, we may have cut some corners, and as we didn't know, and when lives are at stake, we perhaps all of us panicked. However, we always have to come back to that tenets of evidence-based approach, whether it be vitamin D, whether it be hydroxychloroquine, probiotics, or other micronutrients. It's very important to stay updated on the latest science so we can best equip ourselves and best take care of our patients with the best knowledge out there. With that, I'd like to thank everyone who is participating on this webinar. Really, it's been a great session. We will definitely have you back, Dr. Hariri, for a follow-up on this.
Thank you for having me. Thank you very much.
Of course. And just as a reminder, tomorrow we have another webinar on legal aspects of practice of medicine, from the employment and employee aspect of medical practices. Please join us. And next week, Monday, a week from tonight, we will be joined by the president of the California Medical Association, who will be joining us from Sacramento to tell us about, which is the biggest physician advocacy group in California. They will be telling us of what's going on from the legislative aspect of this issue, and what's in store for us as physicians. It's going to be a very informative webinar. We have two tomorrow night, and next Monday really will be a very practical webinars that will impact all of us and our ability to practice medicine. Please join us. With that, I'd like to say good night. Thank you, Dr. Hariri. Thank you, Dr. Barkhudarian. Please be safe out there. Please take care of yourselves. Please heed all the advice from our public health officials. It's simple stuff. It is a little bit inconvenient, but it could potentially save lives. So let's all together be safe out there. Take care of yourselves, take care of your loved ones, and of course, take care of your patients. Have a great evening.
Thank you, Viken. Thank you, Sherwin.